Good evening, everyone. Welcome to today's Fireside Chat. This, just of note, this is going to be 127th webinar series. So it means we have been doing quite a number. My name is Dr. Yuri Okech. I'm the Country Medical Director for AHN Kenya. I'll be your host today. So I'll be moderating this session with the assistance of Dr. Lloyd and also Dr. David. So we have a very interesting topic today, which will be on the risk factors for hypertension in children and adolescents. And our presenter for today will be Professor Rajendra Bhimma, who is a full professor of pediatrics at the University of KwaZulu-Natal, and a specialist pediatric nephrologist at the Inkosi Albert Luthuli Central Hospital in Mayville, KwaZulu-Natal, South Africa. He is also the deputy chair of the Biomedical Research Ethics Committee and an executive member of the Higher Degrees Committee of the University of KwaZulu-Natal. He is a member of both the National and International Nephrology Societies. He is a co-editor, academic editor of 5 peer-reviewed journals. His main research area, his interest is in the glomerular diseases in children, particularly nephrotic syndrome and pediatric hypertension. And he also serves as a reviewer for several local and international journals in pediatrics and nephrology. So without further ado, welcome Professor Rajendra. We look forward to the very, very informative and presentation. So welcome, Professor.
Thank you, Yuri, for those kind words. I really appreciate that. Good evening to the panelists and to all the attendees. And I must thank the organizers for giving me this opportunity of presenting to you today. Actually, I am going to do this talk in 2 parts. One is the risk factors for hypertension in children and adolescents. And then I'm going to briefly speak to you about something that's quite practical, and that is hypertensive emergencies. And then Dr. Lloyd said I should present a few cases. So we'll do 2 or 3 cases and just see after the talk whether you have a feel for it or not. So I'll ask the question to the adult colleagues, don't worry. For the pediatric people, it will be all that. Okay, so let's just start with risk factors for hypertension in children and adolescents. I just put this on slide. So if you look at childhood hypertension, it is something that contributes to the early development of cardiovascular disease in adults. And the thing is, it is something that we have to pay particular attention to, because the prevalence of primary hypertension in childhood and adolescence is on the rise. And regardless of its etiology, hypertension in childhood results in significant end organ damage. So whether it's primary or secondary hypertension doesn't matter. It still results in end organ damage. Oh, sorry. Okay, so if you look at primary hypertension in childhood, it's divided into 2 categories based on the presence or absence of any underlying etiology. That means if you can't identify a cause, it's called primary hypertension. Of course, if you can identify a cause, it's called secondary hypertension. And at one stage, secondary hypertension was thought to be the mainly responsible for over 95% cases of hypertension in childhood. But now primary hypertension is on the rise, and it's a topic of particular interest to us, particularly as nephrologists. Just before I go on, this is not a lecture on hypertension, it's on risk factors, but I thought I'd just look at the new classification of pediatric hypertension as per the American Academy of Pediatrics. So previously, hypertension was divided in a similar way. It was normal blood pressure, and then we had what is called pre-hypertension and then hypertension. But now pre-hypertension is changed to elevated blood pressure. And once again, hypertension is divided into stage 1 and stage 2 hypertension. But what's interesting is now they divide it into 2 categories. And the 2 categories are those for children between 1 to less than 13 years of age, and those for children between 13 years and above, up to less than 18 years. Of course, 18 years above will be what the adults use for their criteria. So if you look at normal blood pressure, in less than 13-year-olds, it is a systolic or diastolic blood pressure less than the 90th percentile. And that's corrected for age, height, and sex. For children over 13 years of age, normal blood pressure is defined as a systolic blood pressure less than 120 and a diastolic blood pressure less than 80 millimeters of mercury. So that's different from the old classification, which was just less than 90% percentile. If you look at elevated blood pressure, and that was called pre-hypertension previously, in less than 13-year-olds, it is a systolic and diastolic blood pressure greater than the 90th percentile to less than the 95th percentile, or 120 over 80 millimeters of mercury to less than the 95th percentile, whichever is the lower of the two. Okay, that might sound a bit confusing, but actually it's quite important to look at that category, because these patients here are the ones that are often missed. Now, in over 13-year-olds, the systolic blood pressure of 120 to 129 or a diastolic blood pressure of less than 80 millimeters of mercury is defined as elevated blood pressure. If you look at hypertension, it is divided into two categories, stage 1 and stage 2. Now, in less than 13-year-olds, it is a systolic and diastolic blood pressure greater than the 95th percentile to less than the 95th percentile plus 12 millimeters of mercury. Now, this is the part that was different. Previously, we just had greater than 95th percentile to less than the 99th percentile. Or you look at a blood pressure of 130 over 80 millimeters mercury to 139 over 89 millimeters of mercury. So whichever is the lower of the two is what is considered. Anything above that would be considered stage 1 hypertension. So that's quite a bit to take in for stage 1 hypertension. But if you work it out on the centile chart, it's actually not so difficult. For children greater than the 13 years of age, it is a blood pressure of between 130 to 80 to 139 over 89 millimeters of mercury. Okay, any blood pressure above that is stage 1 hypertension. And then stage 2 hypertension is defined as a systolic and diastolic blood pressure greater than the 95th percentile plus 12 millimeters of mercury, or greater than 140 over 90 millimeters of mercury, whichever one is the lower of the two. And then for greater than 13 years, it is greater than equal to 140 over 90 millimeters of mercury. So this is the new classification that's been used. It's slightly different from the European classification, but I think this is the most widely used classification. And so now all the centile charts, etc., are using this to classify hypertension in childhood. So what are the risk factors for primary hypertension in childhood? Well, basically, we can divide the risk factors into those that are modifiable and those that are non-modifiable. So what are the modifiable risk factors that we have in children and adolescents? The first is dietary sodium intake, obesity, breastfeeding. Then we have white coat hypertension and mass hypertension, tobacco exposure, childhood adversity, and then prenatal and neonatal factors. And I'm going to go through each one of this in a little more detail. The non-modifiable factors we have, that means we can't do much about this, is sex of the child, the race of the child, and then, of course, the family history. And those are factors that we cannot modify, okay? So let's go into more detail onto the modifiable factors. And first on the list was dietary sodium intake. We know that blood pressure increases with increasing salt intake. Increasing systolic blood pressure in children with increased sodium intake is based on the US NAIN study. And that was a very large study that was done. And what they showed that was with increased salt intake, defined as a sodium intake of greater than 1.5 times the recommended dietary intake, was associated with increasing blood pressure, okay? And that's a study that I've referenced for you there. So as you increase your sodium intake in children, blood pressure also goes up. It's very similar to what you see in adults. And then what about obesity? Well, we know that there is a strong association of rising blood pressure trends with increasing weight gain. And this has been documented in several reports. Now, I didn't want to go into the details of the report. What I did was just reference it for you. You can check up the references. And every study consistently showed this, except in the Bogalusa heart study, they showed no increase in blood pressure despite a rise in the prevalence of obesity from 6 to 17%. And this was between 1974 to 1993. But I think the problem was at that stage that the normative values for hypertension were not very clearly defined in childhood. And therefore, it might be that this may be the reason why the study failed to show a linear correlation between increasing weight gain and hypertension. What about breastfeeding? Two prospective studies showed breastfeeding is associated with low blood pressures in childhood. In the first study, there was about 7,276 infants were evaluated at 7.5 years of age. And what they showed was that there was a reduction in both systolic and diastolic blood pressure in infants who were exclusively breastfed. And the systolic blood pressure reduction increased with the duration of breastfeeding. So not only was the introduction of breastfeeding associated with decrease in blood pressure, but the duration of blood pressure, the duration of breastfeeding for a longer period showed you had a reduction in your systolic blood pressure. The impact on diastolic blood pressure didn't come out significant. In the second study, they evaluated about 7,223 singleton infants at 5 years of age. And what they showed was that those who were breastfed for 6 months had a systolic blood pressure that was 1.2 millimeters lower than in infants who had been breastfed for less than 6 months or had been not breastfed at all. So once again, you can see that breastfeeding has a significant impact on the development of hypertension. The absence of breastfeeding leads to a high incidence of blood pressure in childhood. And a shorter duration of blood pressure of breastfeeding is associated with rising increase in particularly systolic blood pressure. What we are all too familiar with in pediatrics is white coat hypertension. So what is white coat hypertension? Is defined as an offered blood pressure reading greater than the 95th percentile, but normal blood pressure values outside the clinical setting. So white coat hypertension in childhood represents two populations. And the two populations, one that is destined to develop primary hypertension, and two, the ones that remain normative even outside the clinical setting. So it is not a benign phenomenon, okay? And in one retrospective study of hypertension, approximately 2/3 of children who had white coat hypertension had either left ventricular hypertrophy or a systolic blood pressure greater than the 95th percentile corrected for age, sex, and height during the treadmill exercise. Now, I was quite surprised to read this because I always thought that this was a transient phenomenon and that once you eliminated white coat hypertension, you know, there would be no impact on it. But it seems that this is definitely something that we have to pay more attention to, because in a category of patients, it can lead to development of hypertension, particularly pre-hypertension. The opposite of white coat hypertension, of course, is masked hypertension. Now, masked hypertension is defined as a normal blood pressure in the clinic or office, but a high ambulatory blood pressure outside the office. And this includes homes. So even in the home setting, these patients have a high blood pressure, but if they come to office, they have a normal blood pressure. Now, when do you suspect this? And the high-risk groups are where you have previously elevated clinic blood pressure readings and a lack of correlation between clinic blood pressure and evidence of end-organ damage, or in obese individuals. And the last category is the most important, okay? Often these patients may have normal blood pressure at the clinic, but when you do ambulatory blood pressure readings, have been shown that they actually have pre-hypertension or even stage 1 hypertension. Tobacco exposure, now one would think that this will be relevant only to the adult population, but surprising enough, we are seeing increasing number of adolescents who are now starting to experiment with tobacco. And both active and passive tobacco exposure increases blood pressure in children. Now, I wasn't aware of this, but there's a new thing that's in the literature about called vaping. And this is something that is supposed to be, well, it's marketed as being less toxic than tobacco smoke, and something that is very trendy, and something that even parents don't mind the adolescent children doing this. But the problem is we don't really know what the effects of vaping is on hypertension. And unless someone else got some literature on it, I haven't come across anything that actually reports on this. But from the rest of the outside of hypertension, the rest of the literature shows that vaping is no less toxic than actual tobacco exposure. So I don't know how safe this is, and perhaps we can discuss this later. Childhood adversity. This is very important, okay? Often you get bullying at school, etc. And observational data has linked childhood adverse effects with increased risk of overweight and obesity in childhood. Children who have bullied at school, etc., often try and get comfort in some ways. And one of the things they do is they eat comfort food. A lot of it is fast foods, etc. And of course, as a result of this, they develop obesity, and there's increased risk of coronary artery disease and stroke and hypertension in adult life. So this is something also that as pediatricians, we should be paying attention to. And if you find a child with high blood pressure, always go into the history and check with the child. Often these children don't admit to it. And if you can't find identifiable cause, maybe it's a good idea to get the child to speak to a psychologist or something and see if there's something at school that's leading to the child having increasing weight and hypertension. Because childhood adversity is quite common nowadays, particularly in the South African setting. I don't know what it is elsewhere, but this is something that we are starting to pay more attention to. What about perinatal and neonatal factors? There's increasing evidence to show that perinatal and neonatal factors contribute to high blood pressure in childhood and adolescence. And we know from the Barker hypothesis that low birth weight predisposes to development of primary hypertension. How this happens is if you have patients who have low birth weight, prematurity, etc., they have a lower nephron mass. Of course, when the baby is small and in childhood, that's less of a problem, but as they grow and there is increased demand for filtration taking place, then these patients have hyperfiltration and of course they develop hypertension. And that's the Barker hypothesis. There's in utero exposure to preeclampsia is associated with an increase in systolic and diastolic blood pressure and an increase in body mass index. And this is well known, okay? My colleague who does a lot of work on preeclampsia told me that when they have a patient with preeclampsia, they always warn the pediatrician that, look, this child who is born should be screened at a later stage for hypertension. And there's a strong correlation between preeclampsia and eclampsia and the development of childhood hypertension. What's interesting is that for children with chronic kidney disease, there appears to be no additional effect of an abnormal birth history on blood pressure. And I'm not sure why this is so, but it may be because it's hard to dissociate chronic kidney disease and the development of hypertension as opposed to primary hypertension. And it's just maybe that may be the reason why there was difficult to show on logistical regression analysis a correlation between chronic kidney disease and increased risk for developing hypertension. So those were the modifiable factors that we can look at and we can do something about. Now, what about the non-modifiable factors? And these are factors, of course, we can't do anything about. What do we know about that? Well, with sex, we know that the prevalence of hypertension and prehypertension is greater in males as opposed to females. And in a Canadian cohort study of adolescents, it was shown that boys were more likely to have higher systolic blood pressure. That means greater than the 90th percentile, compared with girls in the 7th, 9th, and 11th grades. And you can see that as the children get older, they progress from the 7th to the 9th grade, the odds ratio for them developing hypertension correspondingly increases. You start from an odds ratio of 1.29 in the 7th grade to an odds ratio of 1.98 in the 9th grade to an odds ratio of 2.74 in the 11th grade. So obviously, with increasing age, there is a greater correlation with the development of hypertension. What about the impact of race on hypertension? The incidence of hypertension is greater in Blacks and Hispanic children in the USA compared to whites and Asian children. At the moment, I don't know what is elsewhere, but we are about to engage in a major study that will look at hypertension normative values in our population, and we are hoping that data comes out after a few years, and then I'll be able to tell you whether there's a difference in our population group or not. But in a large study of about 2,368 girls who are enrolled at the age of 9 to 10 years in the National Heart, Lung, and Blood Pressure Institute Growth and Heart Study from 1986 to 1997, the overall incidence of hypertension based upon 2 clinic visits was greater in Black girls compared with white girls. And it was 5% versus 2.1%. when measured at annual visits to the age of 18 to 19. And that came out quite significant. Okay, so it seems that race does have an impact on the incidence of hypertension. And then lastly, what about family history? A family history of hypertension is present in approximately 50% of hypertension. If you have both parents that are hypertensive, you're more likely to have the child that is hypertensive as opposed to one parent. This has been shown quite clearly. Now, in children with primary hypertension, elevated blood pressure is thought to result from an interaction of multiple genes and environmental factors. So what's our evidence for this is that the blood pressure correlation is stronger between parents and children than between spouses. Okay, so if both parents have blood pressure, the child is likely to develop hypertension. However, if one parent has blood pressure, it doesn't mean to the spouse is going to develop it. Okay, there's no correlation. Okay, so it is a lineage. There's no significant blood pressure correlation between parents and adopted children because they don't share genes, right? Although the environmental factors may be the same. And then blood pressure correlation is stronger between identical monozygotic twins than between dizygotic twins. So that is pretty strong evidence that genetics plays quite a strong role in the development of hypertension in childhood. So let's just summarize some of the risk factors that can contribute to high blood pressure in children. And the first I said was obesity. So children who are overweight or obese are more likely to develop high blood pressure than children who maintain a healthy weight. With regards to family history, if there's a family history of high blood pressure, then children are more likely to develop this condition. A sedentary lifestyle, lack of physical activity and exercise, which predisposes to obesity, is a major risk factor for high blood pressure in children. Nowadays, you know, I don't know what it is in other countries, but in South Africa, with the crime rate and everything else that's going on, children hardly ever play outside. They're always indoors, either on the phones, on the tablets, or watching TV. And there's a lack of physical activity, and that predisposes to obesity. And of course, with obesity, we're seeing a rise in hypertension in childhood. Unhealthy diets. Eating a diet that is high in salt, saturated fats, and processed foods can contribute to high blood pressure. And we are seeing this increasingly, especially with the economy becoming more strained. Both parents are forced to get to work. And the easiest thing to do is not to make lunch for your child, but just give him some money and say, go to the tuck shop and buy yourself a burger and a Coke. Okay, the worst thing you can do. So we are seeing this, unhealthy diets. Chronic health conditions like certain chronic health, such as kidney disease or diabetes in children, can increase the risk of high blood pressure. And then sleep disorders can also do this, right? And I didn't stress this enough in that because it's one of those that are difficult to pick up, but it's been shown that sleep disorders can increase the risk of high blood pressure in children. And what about stress? And I brought this out, that if you find a child with hypertension, always look for stress in the child. It may be stress at school, maybe it's domestic upheaval or whatever it is, and that, of course, predisposes them to hypertension. And this can be quite sustained and as well predisposed to hypertension as they grow up. So in summary, those are some of the factors that can contribute to high blood pressure in children and in adolescents. And as I said, some of these factors are modifiable and some of the factors are not. So what can we say in conclusion is that primary hypertension in childhood and adolescence is on the rise. Screening for hypertension should be done at each hospital visit, and you must look for these modifiable factors. And if you find them, you can try and do something about them, okay? And manage them appropriately. And this is particularly so in those where there are multiple risk factors, okay? And those who have multiple risk factors are much more predisposed to developing hypertension than those who have a single risk factor. So that concludes the first part of this talk, and those were the risk factors for hypertension. So I'm going to go on to the second part of the talk now, which is something that I was asked to do by some of my trainees, and that is hypertensive crisis in children and adolescents. And this is a medical emergency, and if it is missed or inappropriately managed, it can have devastating consequences. What's the definition of a hypertensive crisis? A hypertensive crisis is defined as an acute elevation of blood pressure that can cause rapid end organ damage. And just for my adult colleagues, we so often read the blood pressure and we look at it, and if it's not above 140/90, we say, oh, wow, that's fine. But this little cartoon here is very important. It says blood pressure looks okay. Wait a minute, this is a kid, okay? A child's blood pressure of 149/89 may be very, very high, okay? Depending on the age of the child, depending on the height of the child, and depending on the sex of the child. These are the three biometrics that affect blood pressure. So when you're looking at children, if ever you're taking your blood pressure, 140/90 is not your cutoff. That might be severe hypertension, stage 2 hypertension. So always be careful about what the age of the child is and and then read your blood pressures according to the normative values that I previously discussed in the first part of this talk. So that was the values that I went through. I'm not going to go through it again. But when do we suspect that a child may develop a hypertensive crisis? The thing is, there's no absolute blood pressure threshold to define this crisis. So you can have a child who can develop a crisis at a blood pressure of 120/80, which is normal for an adult, when the child's normal blood pressure should actually be 98/64 or something. I'm just taking an example, okay? So there's no actually cutoff threshold. And this can occur in children who do not have any pre-existing hypertension, okay? It doesn't have to have chronic kidney disease or anything. It might just occur like that, de novo. So when can you suspect this? And as I said, it's very difficult because the hypertensive crisis is, there's no cutoff for it. The European Society of Hypertension proposes that a value of 20% above stage 2 hypertension should be viewed with caution. Okay, that means if you above 20% above the threshold for stage 2 hypertension, you must worry that this child can develop a hypertensive crisis. The American Academy of Pediatric guidelines states that clinicians should be concerned about the development of target end organ damage when a child's blood pressure increases 30 millimeters or more above the 95th percentile for age, sex, and height. Now, I'm not sure which of the one of the two is higher, but this is the American Academy of Pediatrics. So two different versions of it. But just to let you know that I always look at it and use the first one and say, if the blood pressure is above 20%, then this child needs to be closely monitored. Okay, it should be in a high care setting. It is important to note that the absolute degree of blood pressure elevation is less important than whether end organ symptoms or damage are present. Okay, so if the child is symptomatic, never mind how high the blood pressure is. Once a child is symptomatic, that child is at high risk for developing a crisis. And the potential for life-threatening end organ damage determines the timing and intensity of managing the hypertensive crisis. So that last sentence is very important, okay? You want to prevent end organ damage, and remember, this can be quite severe, right? And we'll go through what the end organ damage is shortly. So if you look at the classification of hypertensive crisis, it's divided into two categories, right? The first is a hypertensive emergency, and the second one is a hypertensive urgency. So what's the difference between the two? Now, in a hypertensive emergency, there's a life-threatening condition associated with severe blood pressure elevation and end organ damage. So there's two things. There's an elevation of blood pressure which is associated with end organ damage, but the most important thing is that this can be life-threatening, right? And because it is life-threatening, immediate intervention with increasing antihypertensive drugs is mandatory. So in this setting, it is almost mandatory to use an intravenous antihypertensive agent. On the other hand, you have a hypertensive urgency, and this constitutes a sudden severe rise in blood pressure, but there's no evidence of end organ damage. And this condition is not life-threatening, okay? So although there's still a rise in blood, and it may be higher than the one that you have in the hypertensive emergency, because there's no symptoms or signs of end organ damage and it's not life-threatening, this is usually asymptomatic, and these patients can be managed with oral antihypertensive agents. So this is the less severe of the two categories. So what's the clinical presentation of a hypertensive emergency? If you have urgency, as I said, it's usually asymptomatic. And although we are saying asymptomatic, some of them may have end organ damage, such as left ventricular hypertrophy if it's long-standing hypertension, like in the patient with chronic kidney disease, or hypertensive retinopathy or microalbuminuria. That means they have long-standing hypertension and the blood pressure goes up, but they are not symptomatic from it, although they have evidence of end organ damage. However, if you have a hypertensive emergency, this can affect three main organs, which are the brain, the kidneys, and the heart. And with hypertensive encephalopathy, which is the most important, you develop a condition which is called posterior reversible encephalopathy syndrome. And this is often associated with nausea and vomiting. And of course, these patients can progress to develop convulsions. What are some of the other symptoms that are associated with this condition? You can get confusion, you can get visual disturbances, you can get stupor, focal neurological deficits, status epilepticus, or even progress to coma, or if they have heart failure, they can have shortness of breath and anxiety and sweating, etc. So depending on which organ system is involved, okay, the symptomatology varies. So what's our evaluation of a child with a hypertensive crisis? Of course, you take a detailed history and physical examination for evaluating all the risk factors, and the history must include any ingestion or exposure to toxins, medications, or even non-medicinal compounds, okay, which can often raise the blood pressure. And more remote events of the child's birth history, such as prematurity, a history of umbilical artery catheterization, birth asphyxia should be included, depending on the age of the child, okay? And a history of urinary tract infections or frequent illnesses as a young child raises the possibility of kidney scarring or reflux nephropathy, which often can lead to hypertension in childhood. And of course, I told you about preeclampsia, but in adolescent girls, always bear the possibility of the patient themselves having preeclampsia, right? Pregnancy, okay? And I've been caught up twice with this, okay? So these patients can develop hypertension. And episodes of diaphoresis, palpitations, pallor, or flushing may suggest a metabolic or endocrine disorder. So symptomatology varies depending on the organ system involved and depending on what the etiology of the or underlying cause of the hypertension is. What are some of the presenting features in children with a hypertensive crisis? Now, we divide this into two categories, and I like this classification because it helps you to think about this problem. And that is in infants and young children who are less than 6 years old, they may just present with irritability and nothing else, okay? You walk into the ward and this child is not behaving normally like it should. He's got chronic kidney disease and you wonder what's going on, and you check his blood pressure and it's highly elevated. I have seen this twice. Feeding disturbances, especially in young children with vomiting, and then failure to thrive, and seizure activity. Seizure activity, of course, is a no-brainer because once they get seizures, the first thing you have to do is check the blood pressure, okay? Then you have altered mental status or any signs of congestive heart failure, okay? Those are things that can lead to a hypertensive crisis. Alert you of that. In older children, you get headaches and dizziness or acute visual disturbances. Sometimes they may have non-localizing signs like facial nerve palsies. If they have a heart failure, they can get tightness of chest tightness or shortness of breath, tachycardia, palpitations, and often they have nausea or vomiting. But sometimes they may be totally asymptomatic, okay? So these are the type of symptoms that patients may present with a hypertensive crisis. Now, some of the signs that they can present with, I'm not going to go into great detail, but I think this is quite an exhaustive list, okay? But the ones that we look for, as I said, the brain, the kidney, and the heart. And so you examine the patients to see whether any of these organs are first involved, and then, of course, all the endocrine features, and then any neurological signs like basically, the presence of any neurocutaneous lesions associated with tuberous sclerosis or neurofibromatosis, anything else that may predispose to hypertension. And just remember that the list is quite exhaustive, and so you have to examine these patients very carefully and find out what actually is could be the underlying cause, okay? And then, what are the treatment guidelines for hypertensive crisis? The American Academy of Pediatric guidelines recommend that intravenous agents only be used when oral administration is impossible due to the child's clinical state or any other complication that have already developed. Now, that is fine, but as I said, with a hypertensive crisis emergency, we should preferably use intravenous agents, right? They are saying that you only use it if you can't use oral administration. I don't know how that is true, but this is what the American Academy of Pediatric guidelines state. And blood pressure is reduced by almost 25% of the desired target reduction in the first 8 hours, and then achieving blood pressure targets in the next 12 to 24 hours. So I always tell my trainees that the management of a hypertensive crisis is what you call in Latin festina lente. It means hurry up slowly. Now that's almost an oxymoron. Okay, you can't hurry up and then go slowly. But that's exactly what it is, because you don't want to rapidly drop the blood pressure to its normal target level. Okay, if you do that, you might precipitate a cardiovascular accident, or you might push the child into heart failure. So what you do is, here they say 25%, but as a rule of thumb, I always say, follow the rules of third. You drop 1/3 of the blood pressure in the first hour, another third in the next 8 hours, and the rest in the next 24 to 48 hours. And that works reasonably well, okay? It's easy to remember that rule of thirds. Now, before initiating antihypertensive therapy, it's important to identify patients for whom rapid blood pressure lowering is contraindicated. So what are the contraindications to rapidly lowering blood pressure? And the first and foremost is patients with raised intracranial pressure. If you have a child with a neurological problem and you suspect there is raised intracranial pressure, remember, with that raised intracranial pressure, they are relying on that high blood pressure to perfuse the brain. If you go in and rapidly drop that blood pressure, you're going to precipitate an infarct. Okay, so that's one absolute contraindication, right? The other is coarctation of the aorta. Remember, with the coarctation, they're relying on the hypertension to perfuse the rest of the body and the brain, etc. And if you drop the blood pressure, you can push them into failure, or even once again precipitate a cardiovascular accident. Then patients requiring therapy directed at the cause of the high blood pressure, example, patients with severe pain who require stronger analgesia. And often we see this, okay? Post-surgical patients, etc. You get called in to consult because the blood pressure is elevated. And you ask the sister, and what analgesia has been written up? Oh no, it's just on paracetamol. Okay, post-surgery paracetamol is not going to do it. Okay, so you prescribe an opioid analgesic and say, okay, measure the blood pressure and tell me what it is in the next 4 hours or so. And then when you come back, that blood pressure is pretty normal once you get rid of the pain. Remember, in adolescent girls, I told you preeclampsia and eclampsia can be a problem, especially greater than 34 weeks gestation or in the early postpartum period. So this is something that you have to pay attention to. Often the use of illicit drugs like cocaine or amphetamines or other sympathomimetic stimulants with overdoses can lead to high blood pressure. And if you don't pick it up in the adolescent patient, you will be treating the blood pressure but not treating the cause of it. Pheochromocytomas can lead to sudden elevation in blood pressures, and then, of course, snake bites, etc., with increased sympathetic hyperactivity. So those are cases where you want to treat the cause rather than the symptom of the high blood pressure. So what's your initial management is exactly what we always do in any crisis, medical emergency. You have airway support, breathing and circulatory support. And wherever possible, try and get confirmation of the cause of the blood pressure elevation. And of course, you must monitor it closely and determine if there are signs or symptoms of end organ damage. And then, of course, identification of conditions that alter your blood pressure management, which I just been through, like raised intracranial pressure, etc. And the drugs that we have available here, and I don't know what's available in your country, but we have a very limited number of agents that are available to treat hypertension. The commonest drug that we use is labetalol. This is an alpha and beta blocker. And the bolus dosing is about 0.2 to 1 milligram per kilogram per dose, up to a maximum of 40 milligram per dose. And often we give it as a continuous infusion in a high care setting with continuous blood pressure monitoring. The good thing about labetalol, it has quite a rapid onset of action. And if given intravenously, you can titrate the dose, okay? And you can go up to a dose of 3 milligrams per kilogram body weight. And by titrating the dose, you have a good control of how you gradually can lower the blood pressure. Remember, I told you, in many situations, you don't want to rapidly lower the blood pressure, because if you do that, you can precipitate a cardiovascular accident. So what are some of the adverse effects that we see from labetalol? Is things like hypotension, dizziness, nausea, bradycardia. It's contraindicated in patients who have severe asthma, etc., because being a beta blocker, you're not going to give it to those group of patients, right? You must use an alternative antihypertensive. It should be avoided in those who have heart failure as well, because of course, being a beta blocker, you don't want to precipitate heart failure in these patients. So those are the two main contraindications. Of course, if you have allergy to the drug or something like that, you don't want to use it. But other than that, outside of those two major contraindications, it is a very safe drug to use. We use it a lot, and we've got a lot of experience with it. And I must say, because it's given intravenously and you can titrate the dosage, you can control and gradually drop the blood pressure to the limits that you want. And like I said, I just follow the rules of thirds. In the first hour, you drop the blood pressure by 1/3. In the next 8 hours, you drop it by another third. And in the next 24 to 48 hours, you aim for normalization of blood pressure together with the use of oral antihypertensives. The next drug is sodium nitroprusside. And this drug is a strong vasodilator. It's usually given by a continuous infusion of 0.5 to 10 micrograms per kilogram per minute. And its onset of action is quite rapid. It's less than 2 minutes, but it can cause severe hypotension, palpitations, and flushing. Now, the thing about sodium nitroprusside is administration is important. You can't expose it to light, etc., because it changes to cyanide. And so you have to cover it with an opaque covering, like we use a brown paper bag, etc., so that it's not exposed to sunlight. It's constituted at the time that you need it. But what is important is once you give it for a period of more than 24 hours, you must measure cyanide levels because of cyanide toxicity. And this is especially occurs with prolonged usage or when administered those with concomitant renal failure or liver failure. So if you have a patient with kidney failure or liver failure, you must it is much more important that you measure your cyanide levels because you can cause cyanide toxicity in these patients. So that's the second agent that we have. If we can't use labetalol for any, or because the patient is asthmatic or has got heart failure or something, we use sodium nitroprusside. And the third agent that we use often in emergency setting, if we can't have a high case bed or ICU setting, we use oral nifedipine. It's a very effective agent. It's action, whether you give it by bite or you swallow it, it doesn't matter. You know, people used to say that you must break the capsule and then put it under your tongue, etc. It makes no difference, right? It works, takes a bit of while. It works in about 20 to 30 minutes when taken as a whole capsule, and it's quite effective. The problem is that given orally, you cannot titrate the dose. Once you give the dose, depending on the weight of the child and the age of the child, it's given, and so it dropped the blood pressure, right? So you can't titrate and say, I want to drop the blood pressure by a third or so. But in an emergency situation, if you don't have any of the two agents or you can't want to do intravenous monitoring, etc., you want to give this agent, it's fine. Some of the adverse effects that you see are hypotension, flushing, tachycardia, and syncope. And I must say, if you look at even our EDL, they say that it's not recommended. So usually the guidelines don't recommend it, but I've used it as an emergency drug when I had my back against the wall. And I must tell you, it's quite effective and it helps, okay? And we've averted quite a few patients to have hypertensive crises, okay? So although the guidelines don't recommend its use, it can be used. There's a whole lot of other agents that can be used. I think especially in the United States, they are used to using clonidine and enalaprilat. And when I worked in Canada, we used to use quite a bit of esmolol, which is a beta blocker, and enalaprilat. And then, of course, the other agent which we used to use previously, but now it's not available for us for some reason, is intravenous hydralazine, okay? And that was another drug that was available. Now, hydralazine also can be used both intravenously and in an emergency situation. If you can't get any other agent, it even can be given intramuscularly. The dose is about 0.1 to 0.6 milligrams per kilogram. And being a vasodilator, of course, it can cause flushing, headaches, and you can get, the patients develop hypotension. But it's also an agent that can be used in emergency setting. So it's quite a useful agent. I must say we don't have it available now. We only got oral hydralazine in our country, but it can be used, and I'm not sure if any of you have it. And the other one is minoxidil. We use this for quite severe hypertension, or what we call resistant hypertension, but it can be used in a crisis situation, and it's given orally. But once again, you cannot titrate the dose, but it's quite an effective agent. And although the adverse effects are written there, like T-wave changes, etc., I haven't seen it. And I've used it in 1 or 2 patients when I've been stuck and nifedipine is not having an effect, then you can use it. So these are some of the agents that are available, and depending on what you have in your country, and it's important that these patients are monitored and then the blood pressure gradually reduced. So in summary, what we can say that although hypertensive crises are rare in children, it is important that you have prompt detection, thorough evaluation and management to prevent end organ damage and its sequelae. Identification of the underlying cause is necessary, as this helps to guide your treatment, and initial use of intravenous antihypertensive medications in the acute setting allows for judicious titration and gradual reduction of blood pressure, as opposed to oral agents. Although the American Academy of Pediatrics say you should only use that if you can't give it oral. I don't know why. But following a stabilization, a transition to oral therapy for long-term blood pressure control is undertaken. So that's some of the a summary of everything. So Lloyd asked me to do a few cases, so I'm going to present 1 or 2 cases to you and let's see how you do. This was first case is an 8-year-old female, known chronic kidney disease on hemodialysis, and is on 5 antihypertensive agents and received hemodialysis before presentation to hospital. Presented in status epilepticus and acute left hemiparesis with a blood pressure of 184 over 132 millimeters of mercury. On examination, was not edematous, was confused and agitated, but not in respiratory distress, with the chest being clinically clear, but had a gallop rhythm. And the biochemistry is shown there: high potassium, low sodium, normal bicarb and chloride. Of course, the child has got chronic kidney disease, so the urea and creatinine elevated, and the rest of the calcium high phosphate, calcium normal, and magnesium normal. So the question is, what kind of hypertension does this child have? Is this a hypertensive emergency or is it an urgency?
Symptomatic.
Anyone want to volunteer? Yeah. Sorry, which one?
Emergency. Symptomatic. The status
makes it emergency.
Yes, emergency. Yes.
Okay. Wow, you guys are good. Right. Yeah. So basically, this is a hypertensive emergency. So we have a hypertensive crisis with target organ damage. And what we did, of course, we admitted the child to the high care unit, and we have seizure control by giving the child intravenous diazepam and loaded with epilim. And then we did emergency neuroimaging. Fortunately, this child just had press and not an intracranial bleed or something. And we did intraarterial blood pressure monitoring, which is the preferred method of monitoring, and commenced intravenous antihypertensives. And the drug we used here was labetalol and not sodium nitroprusside or esmolol. And we titrated the drug to its desired effect, and then transitioned the patient to oral blood pressure until the to oral agents until the blood pressure was stabilized. Okay, so that's a classical example of a child with a hypertensive emergency. Let's see case 2. 4-year-old presents to the casualty department with shortness of breath, anasarca, and coke-colored urine. Preceding flu-like illness about 2 weeks ago with a blood pressure of 168 over 89 millimeters of mercury. SATs were 89% in room here with a respiratory rate of 45 breaths per minute. Clinically, this child had anasarca with bilateral clackles on the chest auscultation with a gallop rhythm and a Glasgow Coma scale of 15 over 15. And the urine dipstick showed 4+ blood and 2+ protein. Okay. Urgency or emergency?
I will go for urgency. Stand to be corrected.
Urgency. Okay.
I think this patient might be having heart failure. I think it's an emergency.
Okay, so we got urgency and we got emergency. Anyone else got any other take on it? 50-50.
End organ damage is something you don't.
So,
Heart failure.
what would you say?
This is an emergency.
Emergency.
Yes.
Anyone
like
want to contradict that?
It looks like an acute GN. Looks like an acute GN, post-infectious.
Right.
With hypertension, salt retention, and probably fluid overload because saturation is low, pulmonary edema.
Okay, that's good.
So no evidence of target organ damage.
No evidence of target organ damage. So you say this is an urgency, Lloyd?
Yeah, but I don't know the renal function.
Okay, renal function, and this child was pretty normal. Okay, I think so. No, okay, let's see. But do you think this is an urgency or emergency given the clinical findings? Okay, forget the renal function.
Clinical, I would say emergency because the stats are low and gallop rhythm tachycardia.
Yeah.
I would like to, we have
Okay.
to manage it.
Yeah.
Bring the blood
Right.
pressure down.
So that's good. This is a post-streptococcal glomerulonephritis, and we confirmed it with C3 and raised ASOT. The renal function was deranged, right? And I didn't want to tell you that because then you'll give it away. So this is basically a hypertensive emergency once again, okay? Because you got target organ damage, right? So this child was admitted to the high care unit, and a chest X-ray showed cardiomegaly, was commenced on, because the child was in failure, commenced on intravenous furosemide, and we monitored diuretic response, and the child was given calcium channel blockers, and we used, in addition to that, some levetolol, and the blood pressure gradually stabilized over 48 hours, commenced on oral diuretics and a calcium channel blocker, and the child actually did very well. Renal function stabilized, child blood pressure settled, and on follow-up, the child now has a normal UNE. It doesn't mean to say it's normal renal function, but at least, you know, it's not in overt kidney failure or anything. So this child did well, okay? We're still following the child up. Okay, last case. 11-year-old presents with a history of headaches and nausea with a blood pressure of 150 over 105 millimeter of mercury, tachycardia of 130, and nothing else on clinical examination. So we did 24-hour urinary catecholamines, which were elevated, and a CT abdomen showed a left adrenal mass, 5 by 4.2 by 4.1 centimeters. Okay, that's a giveaway. But the question is this an urgency or emergency? Any take on that?
I think this is an urgency.
Urgency.
I would suspect heart failure in a patient who has tachycardia, but that tachycardia might be due to the high catecholamine levels. So I think this might be an urgency. I don't see any evidence of acute target organ damage.
Okay, Joseph, thanks for that. Anyone else got any other take on it?
I would also go for urgency, but I'm a bit worried because of the headaches and nausea. So not very sure whether it's increased ICP, which is now might transcend to emergency.
I must say, we had quite a debate.
Two hands up. Two hands.
Sorry?
Allow them to talk.
Okay, sorry, I couldn't see that.
Two hands.
Okay.
Just unmute, allow them to talk.
Yeah, I just unmute. Who's got the hand up? Go ahead. Any of the attendees? Oh, it's John and Anthony. Yep.
John, Anthony, Addis.
Addis as well. Okay, John's unmuted. Yeah, what is it? Urgency or emergency?
It's hypertensive urgency. It's more of secondary hypertension, secondary to pheochromocytoma. It's more of.
Thanks. John, what's your take on this?
I think it's emergence. We are not sure about the headache and the nausea. Possible there's a sign of increasing intracranial pressure.
Right. Okay. So you think it's an urgency, but you're not sure about that. Anyone got any other take on it?
Dr. Anthony?
Okay. So basically, what we had here was a child with a pheochromocytoma. Okay, that's obvious, right? But remember, I told you that even though you might have the symptoms of headache, etc., that's from the pheochroma, that's from the neuroendocrine effects. Okay, wasn't we did scanning on this patient because I actually was of the view that this was an emergency. Okay, I must tell you, right? So I asked the fellow to scan the patient, etc. Everything came back, no press, no nothing, everything normal. So it actually was an hypertensive urgency, and the preoperative management was the endocrine tumor. But remember one thing about pheochromocytomas, you must first begin an alpha blockade, okay? Right? You don't start with a beta blockade. The reason being that you start with the alpha blockade, and then if the patient starts developing reflex tachycardia, say you commence, then you start the beta blockade to prevent that. And then you must blockade the patients adequately. And the best way to measure that is to feel the pulse, okay? You have to get a pulse rate that is really slow, okay? And once you know the patient is adequately beta blockade, you can then ask the surgeons to go in, because at the time of surgery, if the surgeon stimulates the tumor, you can get a hypertensive crisis on the table. Okay. Anyway, this is not a talk on pheochromocytoma, but I thought I'll just bring it up and let you. So there are 3 different cases. Sorry, I didn't have time to collect more. I just rapidly collected these, but because I was not feeling too well. But I hope they brought out the 2 different extremes of what a hypertensive crisis is. One is an urgency, and the other is an emergency, and the management is slightly different. So in this patient, you can use oral agents, where the other 2 we use intravenous agents. Okay, so that's all for me. I want to thank you for that, and I think I'm happy to take any questions now. Can I start off with what's on the chat?
Yes, Doctor. Yes, Professor.
Thanks. So John asks, what is the prevalence of hypertension among poor families, as you said, associated with unhealthy diet? John, I'm afraid I can't answer that question. I don't know what the prevalence is. But what I can tell you is that in 2016, we did a study in grade 12 students from what we call public schools. Public school means those are funded by the government. They are not these patients who can afford sending the children to private schools, okay? And what we did, we just measured the blood pressures in children 3 times, averaged it out, measured the weight, heights, did all the glucometers and urine for protein creatinine ratios. And what we found was the prevalence of hypertension in grade 12, and I'm not talking about other grades, was 14%. And this was patients who had nothing, no other signs or symptoms of disease. So it seems that primary hypertension is not the 1 to 2% that's described in the previous literature, okay? So I thought the statistician had made a mistake. And so I told the statistician, look, I am not happy with these figures. Please go and relook at it. I want to sit with you and go through the figures. And I was surprised. And to my surprise, Prof. Tony Myers, who's now late, he published on his study from Gauteng, which is a different province from KwaZulu-Natal, where I am. And he had very similar figures. So the prevalence of primary hypertension in poor families is actually on the rise, okay? So that's all I can tell you. It may be anywhere between 14 to 20%. So I can't give you the exact figure, but that's what I have. All right. I hope that answers your question, John. Patrick asks, what are the most effective lifestyle interventions on preventing and managing high blood pressure in children? This is a good question. Now, how do you change lifestyle? It's easier said than done, okay? I told you in South Africa, because of a crime rate, etc., parents are very reluctant to let the kids go out and play in the playground, etc. So what happens is most of them are confined indoors. The best way to entertain them is to put the TV on or give them the iPad or give them a phone, and that keeps them busy. Problem is they don't have any physical activity. So how do you can get around this problem? It's difficult. What's becoming more useful now is they are having gyms that are now accommodating children, etc. So that's one way. The other way is to tell the parents that take your kids on Saturdays or Sundays to the shopping mall and walk from one end of the mall to the other, and you can do window shopping, etc. Of course, the kids want to buy everything, and that's another problem. But you have to try to introduce some type of physical activity. Diet-wise, encourage patients to make homemade meals rather than buying takeouts, etc., which are quick and easy. Problem is, if you look at foods that are high nutritional value, they are more expensive, okay? And being on diet is not cheap, definitely not in my country, okay? I try to do that, to eat very healthy, and my grocery bill went up almost double. So it's a challenge. I can tell you, Patrick, it's not easy to introduce these lifestyle changes, right? But you can tell the parents about what best they can do, right? All right. So it's quite a challenging thing, and I often get help from other social workers, other parents who have some ideas what to do, etc. And there is now a kind of chat group. The parents can exchange ideas, etc. So that's one way of doing it, right? So I hope that answers your question, Patrick. It's not easy, okay? Anonymous attendee, I don't know who this is, but said emergency has hematuria. Or maybe that was answering to the question of the cases, okay? So I don't know what that is. Do you have experience managing children with hypertension on Ritalin? Yeah, this is common. I told you a lot of drugs that can stimulate high blood pressure, and I often see this, right? Particularly in the private sector, where you have a lot of patients who are given Ritalin, and that's becoming like, you know, I don't know, pediatricians are dishing this Ritalin out like it's Panado or aspirin or something, you know, and a lot of patients who are diagnosed with high blood pressure, you take a vehicle history and you ask them, I mean, does your child take anything for his attention? You know, you ask them for his concentration in school. You don't say attention deficit disorder or something. They get worried. Just say for concentration, and they say, yeah, he takes this and that, and it's all Ritalin. And I'm afraid you can't. I try and dissuade the patients from taking this unless it's absolutely necessary, in which case a few of them have come off it and the child have done well, but otherwise you have to treat the hypertension on its merit. Okay. John Caroli asks, can repeat explain blood pressure, breastfeeding versus hypertension. Okay. So breastfeeding, you know, these were longitudinal studies that were done in patients who were breastfed or not breastfed. And what it was shown, there's two things. Infants who are breastfed had a lower incidence of hypertension in childhood compared to infants that were not breastfed. That means they were formula fed. But what was interesting was that the duration of breastfeeding also impacted on hypertension, but it impacted mainly on the systolic blood pressure, not so much on the diastolic blood pressure. The longer you breastfed the child, the less likely was the systolic blood pressure to go up. Okay, so yeah, breastfeeding does have an impact on the development of hypertension in childhood. Okay, that's so much for the chat, Yuri. Any other questions?
Thank you, Professor Rajendra, for the very enlightening discussion. It was a very nice and wonderful learning opportunity for all of us.
I hope so.
Yes, yeah, definitely. I think on my side, I'm a bit worried on some of the modifiable risk factors, especially restricting salt. There we have a lot of salted popcorn. There's a lot of yes, there's chips.
I don't know if you have in your country a thing I just forgot the name now. It's the thing they put on the popcorn. It's not pure salt. It's like a compound. What's it called?
Is it spicy or?
Yeah, it's spicy stuff. I forgot what it's called. But you know, these kids are very used to that, and it's got a very high salt content. It makes it very tasty. Yeah,
I think I've seen it. I think it's like the same thing that they add in what are they called? Like the spaghetti kind of things. I think there's some. Yes, I've seen that quite. I think in some supermarkets. I think it's a craze now. I think also the other bit is the gap in research, especially in vaping, is very common among adolescents. And I think in Kenya there's a craze on something called shisha that people also smoke a lot. Yes, there's something called shisha. So I think probably a lot of research needs to be done on that area about the risk factors of either vaping, shisha, and other recreational drugs that teenagers take nowadays. And again, the issues of a lot of video games, you know, they causes a lot of stress in kids, especially when they don't win games. So yeah, mental health is a struggle. I think it's something that's really cropping up. So thank you again for the very
and we have bullying at schools. You know, bullying plays a very big role. You know,
yes, bullying is
a lot
also,
of my patients have that. See, yeah, no, thank you very much. I appreciate it, and thank you very much for all the attendees for attending this talk. Okay.
Thank you. I'll probably just open the floor to either some of the panelists, either Dr. Lloyd or Dr. David, or anyone who has a question. You can just unmute yourself and maybe ask any questions or clarifications if you have any.
Thank you very much.
Thank you very much, presenter, for the very nice topic. Actually, hypertension in pediatric population is, we think that is a very big problem that is either undiagnosed or underdiagnosed in our settings, because our hospitals mostly, there will not be even a blood pressure machine for children. And most of the drugs will only be for adults. And therefore management of hypertension will be either undermanaged or completely not diagnosed and not managed. So I think this was a very good presentation, and I congratulate the presenter, and maybe we should be, I don't know what we'll do as pediatrician in Tanzania and nephrology NESOT in Tanzania. Maybe there should be somewhere where hypertension in pediatrics should have should be discussed more, and implementation of programs to make us be able to diagnose and treat hypertension in children, especially in areas where we see there's a lot of glomerulonephritis and all this end-stage kidney disease. Now patients, we have a lot of pediatric patients with end-stage renal disease. So that's all. Thank you very much.
Thank you very much, Dr. Shaw, for that. I must say, your comment about the lack of screening for blood pressure in children, and that's not surprising. I mean, I had a rep who was working in a hospital, and my friend introduced me. He was from the adult nephrology unit, and he said, "This is so and so, and by the way, she does this particular beta blocker." I said, "Oh, well, you should come and see me as well because we use it." She said, "But you're the pediatrician. Why do you have to use beta blockers?" I said, "Because we treat hypertension," and she was surprised. So she herself didn't know that. You understand what I mean? So it's not surprising that it's a very neglected field, but with increasing awareness, I think, hopefully we're going to pick up more of these children, because remember, blood pressure in childhood is what predicts blood pressure in adulthood. So many of the patients that we are seeing with so-called primary hypertension in adulthood have their roots in childhood. So we have to pick it up at an early stage before they develop end organ damage. With regards to your comment on the use of drugs, even we are using all the antihypertensive medication that the adult nephrologists are using or adult cardiologists are using, but it's off-label use. I mean, if you look at amlodipine, it's not even registered for use in children under 6 years of age. I mean, there's no literature on it, but we use it even in units, okay? So many of these drugs are used off-label, and we just have to do the best that we can, because we cannot leave these patients untreated. Very few of them are tested in even neonates or in young children. And that's understandable because the incidence of hypertension in childhood is not so high. It's not in a financial interest for companies to investigate its use in children. You know what I mean? It's not a money spinner. But yeah, thank you very much for your comments. And I hope that this is a wake-up call for everyone to start measuring blood pressures in children.
Thank you very much.
Thank you, Professor Rajendra. Just a quick reminder for the participants in Kenya and Tanzania to just find the link in the chat box for CPD points. So kindly fill that. If there are any other questions, you can ask. If there are none, we can leave the chat box open for a while so that at least you get to fill that area. But again, thank you, Dr. Rajendra. Very enlightening, very informative. We have learned a lot, and we can't wait to have you back soon enough to have other more insightful topics.
Thank you very much, Chair, and I appreciate that. Thank you.
Thank you so much,